Chapter is going to talk about several more common respiratory ailments and how we treat or help to relieve the symptoms of those diseases. And we're going to start out by talking about the common cold. Most of the time, the common cold is caused by a virus, either a rhinovirus or an influenza virus. The viruses invade the mucus of the upper respiratory tract, causing an upper respiratory infection, or we call that a URI. The nasal mucosal irritation triggers a sneeze reflex. And then the mucosal irritation in general causes release of several inflammatory and vasoactive substances that cause dilation of the small blood vessels in the nasal sinuses and nasal congestion from excessive mucus production. The mucus, in addition, drips down the pharynx into the esophagus or the larynx, causing cold symptoms of sore throat, coughing, and upset stomach. We call this dripping down the pharynx postnasal drip. Treatments for colds are symptomatic only. You cannot cure a cold. And the treatments involve a combined use of antihistamines, nasal decongestants, antitussives, and expectorants, which is exactly what this chapter is going to talk about. Symptomatic treatment does not eliminate the causative pathogen, and sometimes it's difficult to identify whether the cause is really viral or if there might be a bacterial cause. Treatment is called empiric therapy, which means that we're going to treat the most likely cause. Antivirals and antibiotics may be used, but a definite viral or bacterial cause may not be easily identified. In the pediatric population, there's a concern about a lot of these medications. In 2008, the U.S. Food and Drug Administration issued recommendations that over-the-counter cough and cold products not be given to children younger than 2 years of age. And this is because they may cause oversedation, seizures, tachycardia, and even death in toddlers. Evidence such as medications are simply not effective in small children are another reasons why they stopped utilizing these medications in those young children. Parents are advised to consult their children's pediatrician on the best ways to manage these illnesses. And usually what these mean is that we're going to use non-pharmacologic methods of helping children deal with these symptoms. A 2010 study showed a dramatic decrease in young children's emergency department visits since that 2008 FDA recommendation. So obviously this is something that's been good for children. Here's your first question of the day. The common cold is treated with empiric therapy, which means either the medications cure the cold, or the medications only treat the symptoms. C, herbal medications are useful to eliminate symptoms. Or D, it is prevented with careful use of medications. Well, we just talked about what empiric therapy means. So B would be the most correct. There's no cure for the common cold, and the efficacy of many herbal products are not proven. Treatment rendered can only treat the presenting clinical symptoms. Now, empiric therapy in other diseases may actually result in a cure, but when it comes to the common cold, all it's doing is treating the symptoms. Our last slide alluded to the supplements and herbal products that some people use to either prevent or to treat upper respiratory infections. Vitamin C is an important vitamin and an antioxidant that the body uses to keep you strong and healthy. It's used in the maintenance of bones, muscles, and blood vessels. It also assists in the formation of collagen and helps your body to absorb iron. Vitamin C has been studied for many years as a possible treatment for colds or as a way to prevent them, but findings have been very inconsistent. Overall, experts have found little to no benefit from vitamin C for preventing or treating the common cold. But if it seems to work for you, go ahead. The worst it can do is strengthen your bones, and help with the maintenance of your muscles and your blood vessels, and help you absorb iron. Extracts of echinacea do seem to have an effect on the immune system, and research shows it increases the number of white blood cells, which of course fight infections. A review of more than a dozen studies published in 2014 found that the herbal remedy did have a very slight benefit in preventing colds. So this seems to be one that actually is a good herbal product to use, although we are talking slight benefit. Golden seal is also used for the common cold and some other respiratory tract infections like stuffy nose and hay fever. Some people also use golden seal for digestive orders, including stomach pain, gastritis, peptic ulcers, colitis, diarrhea, constipation, hemorrhoids, and intestinal gas. Golden seal contains the chemical berberine, which might have effects against bacteria and fungi. For example, it can prevent the bacteria E. coli from binding to the urinary tract walls. Berberine also has properties that can lower blood pressure and improve irregular heartbeats. In addition, early research suggests that it can lower blood sugar and bad low-density lipoproteins, or LDL cholesterol. And many of the important chemicals in golden seal are poorly absorbed, though, when taken by mouth, and might not reach the concentrations needed to have any significant effect in humans. So it is unknown whether golden seal has the same benefits as berberine. Some of the things, it's kind of interesting as I was researching it, it also talked about that there is a theory that if you've been using drugs, that if you take golden seal, it will cause your urine screen to be negative for those drugs. Now, that particular myth has been shown to be untrue, that you still will have positive drug screens. So if for some reason you were thinking that it might hide marijuana or some other drug use in your urine screen, sorry, doesn't do that. So the jury's out as far as whether golden seal helps with infections or not, but there's some people who swear by it. Antihistamines are drugs that directly compete with histamine for specific receptor sites. There are two histamine receptors, the H1 and the H2, and we'll talk a little more about each one of them. When we talk about anaphylaxis or a severe allergic reaction, what we're talking about is the release of excessive amounts of histamine that leads to constriction of the smooth muscle, especially in the stomach and in the lungs. And really, we're probably looking more about the release of those histamines and their actions on the lungs. They increase body secretions, and they cause vasodilation and increase capillary permeability. So in other words, we start having movement of fluid out of the blood vessels and into the tissues, and that results in a drop in blood pressure and edema. So if you think about it, this stuff is happening especially in areas that help us breathe. So the constriction of the smooth muscles in the lungs mean that we've got vasoconstriction, and often we get bronchoconstriction as well. And then we end up with edema and increased fluids in the tissues. And like we said, the blood pressure drops out, and these people are really, really sick. As we mentioned about anaphylaxis, histamine is a major inflammatory mediator in many allergic disorders, like allergic rhinitis, so hay fever, dust allergies, pet allergies, anaphylaxis, angioedema, drug fevers, which means the allergic reaction to medications, insect bite reactions. I told you what happens to me when I get stung by a wasp, and urticaria, or itching, that's involved with many of these allergic reactions. So looking at the specific types of antihistamines or histamine antagonists, the H1 antagonists are also called H1 blockers. And examples of these are things like chlorpheniramine, fexofenadine, like Allegra, loratadine, Claritin, cetirizine, which is Zyrtex, and diphenylhydramine, which is Benadryl. So we're familiar with most of these medications. They're H1 antagonists. They're also known as H1 blockers. Antihistamines have several properties. They're antihistaminic. They are also anticholinergic. So think about all of the effects that anticholinergic drugs have. They also have a sedative effect. H2 blockers, or H2 antagonists, are used to reduce gastric acid in peptic ulcer disease, and are also in reflux. Examples of these medications are cimetidine, or Tagamet, ranitidine, which is also known as Zantac, famotidine, which is Pepcid, and nizatidine, which is Axid. The mechanism of action for antihistamines are that they block the action of histamine at the H1 receptor sites. They compete with histamine for binding at unoccupied receptors. They can't push the histamine off the receptor if it's already bound, but it can keep it from getting there in the first place. The binding of the H1 blockers to the histamine receptors prevents the adverse consequences of histamine stimulation, which is primarily vasodilation, increased gastrointestinal and respiratory secretions, and increased capillary permeability. For those of you with allergies, think about all of your symptoms that you get when your allergies hit. You get that vasodilation. So if you look at your face, you actually get a little red around the eyes and around your nasal passages. That's the vasodilation. And then you get increased respiratory secretion, so your nose starts running. But because of this increased capillary permeability, that's what's making you feel like you're so stopped up that you can't breathe. Because if you think about it, the nasal secretions that you have are really thin. They aren't what's causing you not to breathe. It's this edema that's happening due to the capillary permeability. In addition, antihistamines are more effective in preventing the actions of histamine rather than reversing them. Obviously, we talked about the fact that they can't push the histamine off of those receptors, but they can fill up those receptors so that the histamine can't get on them. So that's what they mean with they prevent rather than treat. They should be given early in the treatment before all the histamine binds to the receptors because of that. Just to make sure that we're all thinking about this on the same level, let's review how histamine acts compared to antihistamine. On the cardiovascular system, specifically the small blood vessels, histamine causes dilation and increased permeability, meaning that it allows substances to leak into the tissues. Antihistamines means that it reduces the dilation of the blood vessels and reduces the increased permeability of the blood vessels. Think again about the cholinergic effects and the anticholinergic effects. The cholinergic effects causes the dilation, and the anticholinergic causes constriction. On the smooth muscles of the exocrine glands, the histamine stimulates the salivary, gastric, lacrimal, and bronchial secretions. So in other words, it makes you tear up and your bronchus begins to produce mucus. Antihistamine effects causes a reduction in saliva, gastric, lacrimal or tearing, and bronchial secretions. When we look at the immune system, the mast cells release histamine and other substance resulting in our allergic reactions. The antihistamines bind to the histamine receptors, preventing histamine from causing those responses. When we look at the skin, it reduces the capillary permeability, the wheal and flare formation, and the itching. That's the antihistamines that do that. The anticholinergic effect of the antihistamines is a drying effect that reduces nasal, salivary, and lacrimal gland secretions. So you don't get a runny nose, you don't tear up, and your eyes aren't itchy. Remember that also that antihistamines may cause some drowsiness, some more than others. We pretty much already have an idea of what antihistamines are indicated for. They're used for the management of nasal allergies, seasons or perennial allergic rhinitis, or what we call hay fever, allergic reactions to medications or to other things. They're also used somewhat in Parkinson's disease and for people with sleep disorders. They can also be used to relieve symptoms associated with the common cold, like sneezing and a runny nose, and for palliative treatment, but not curative treatment in this case. Contraindications for antihistamines are obviously known drug allergies, narrow angle glaucoma, cardiac disease and hypertension, kidney disease, bronchial asthma, chronic obstructive pulmonary disease. Think about the fact that these cause constriction in the lungs, and these are diseases that are associated with constriction in the lungs. Sole drug therapy during acute asthmatic attacks. So during asthmatic attacks, we're going to be using albuterol or epinephrine. So antihistamines really are not what we're looking for those, although it may be an adjuvant drug that's used during that time, or an additional one to treat other things that are going on during that asthmatic attack, or maybe even the cause of it. With peptic ulcer disease, we don't want to use it anytime there's a seizure disorder, with BPH or benign prostatic hyperplasia, and with pregnancy. There are certain antihistamines that are considered to be safe during pregnancy. Pregnant women should not just take any over-the-counter medication during pregnancy. Adverse effects associated with antihistamines include those anticholinergic effects like dry mouth, difficulty urinating, constipation, and changes in vision. It can also cause drowsiness, and the drowsiness may actually, in some people, take them into deep sleep. There are some people that will take Benadryl as a sleeping aid because of this drowsiness that it causes. Question number 2. Before administering an antihistamine to a patient, it is most important for the nurse to assess the patient for a history of which condition? Chronic urticaria, motion sickness, urinary retention, or insomnia? I think most of you can probably pick out the answer on this one, which is C, urinary retention. The anticholinergic effects of antihistamines may cause difficulty urinating. The other answers are potential indications for the antihistamine. Two types of antihistamines. The traditional types, which are brompheniramine, chlorpheniramine, diphenhydramate, diphenylhydramine, meclizine, or promethazine. These medications have a tendency to be sedating. They make you tired. When you take them, we usually will say be careful about driving with them because of their sedative effect. And then we have the medications that we call non-sedating, which include loratadine, cetirizine, and fexofenadine. These are newer medications, and they don't tend to have quite the sedating effect that the traditional antihistamines had. The non-sedating or peripherally acting antihistamines were developed to eliminate the unwanted adverse effects, mainly the sedation. They work peripherally to block the actions of histamine. Thus, they get fewer central nervous system adverse effects. They also have a longer duration of action, and that increases compliance with people taking the medications. So examples of these medications are fexofenadine, which is Allegra, loratadine, which is Claritin, and cetirizine, which is Zyrtec. The older traditional antihistamines have been around for a long time. They work both peripherally and centrally. They have anticholinergic effects, making them more effective than the non-sedating drugs in many cases. And examples of these are diphenhydramine, which is Benadryl, brompheniramine, chlorpheniramine, and you can read the rest of them there. So we think they actually tend to have more of the effects that you want. The drawing of the secretions, less vasodilation in the mucosa, However, because they do affect these things stronger, you get a really dry mouth with them, and like like I said, it still causes this sedative effect. Looking at the nursing implications regarding antihistamines, you want to make sure you gather data about the condition or allergic reaction that required treatment. Also assess for drug allergies. They, these antihistamines are contraindicated in the presence of acute asthma attacks and lower respiratory diseases such as pneumonia. Think about it. We don't want secretions to dry up with pneumonia. We want them to be nice and loose so that the person can cough them out. We want to use them with caution in patients with increased intraocular pressure, cardiac or renal disease, hypertension, asthma, COPD, peptic ulcer disease, BPH, or pregnancy. Be sure to instruct your patients to report excessive sedation, confusion, or hypotension. And really, we ought to be telling them not to take it if they notice those symptoms because most of these meds are available over the counter. Instruct your patients to avoid driving or operating heavy machinery and advise against consuming alcohol or other CNS depressants when they're taking these medications. Instruct patients not to take these medications with other prescribed or over-the-counter medications without checking with their prescribers. There are specific antihistamines that can be used by people who have hypertension. And so it's important that they talk to their physician about which antihistamine they can use if they have a history of hypertension, for instance. Antihistamines are best tolerated when taken with meals. It reduces the effect on the GI system, and they'll have less GI upset with it. If dry mouth occurs, teach the patients to perform frequent mouth care, chew gum, or suck on hard candy, preferably sugarless, to ease their discomfort. Also, monitor for the intended therapeutic effects. One other thing I wanted to point out here is that it's not unusual for children to have paradoxical response to these medications. In other words, instead of getting sedated, children will often become hyperactive when taking things like Benadryl. So parents ought to be warned that that's a possibility. I would say that most of you already know what nasal congestion is, and it's usually caused from excessive nasal secretions and the inflamed and swollen nasal mucosa. The primary cause are allergies and upper respiratory infections like the common cold. When a person is congested, they need a decongestant. So there's three main types that are used. Adrenergics, which are the largest group of decongestants, and which include the sympathomimetics, anticholinergics, which are less commonly used, that include the parasympatholytics, and corticosteroids, which are topical or intranasal steroids. And there's two dosage forms, oral or inhaled or topically applied to the nasal membranes. Oral decongestants have prolonged effects, but they have a delayed onset. So in other words, it takes a while for them to get going, but once they get going, they last longer. The effect is less potent than the topical effects. However, there's no rebound congestion with the use of oral decongestants compared to the sprays, for instance. Uh, they are exclusively adrenergics, and examples of these are like pseudoephedrine, which is Sudafed. Topical nasal decongestants are actually topical adrenergic drugs. They have prompt onset because they're being applied directly to the area that's being affected. They're very potent. Their sustained use over several days can cause a rebound congestion when they stop taking it, making the condition actually worse. So, the medications that are associated with these are ephedrine, oxymetazoline, phenylephrine, and tetrahydrolazine. These are, if you think about it, one brand in particular that comes to my mind is Afrin. Afrin is a nasal spray, and you get really fast results from them. It works wonderfully. But the problem is that if you take it for more than about 5 to 7 days, you will, when you stop taking it, all of a sudden you'll get even more congested than what you were to start out with. There are people that actually are addicted, so to speak, to Afrin because they've taken it for such a long period of time that they almost have to wean off of it so that they don't have profound congestion. Inhaled intranasal steroids and anticholinergic drugs are not associated with rebound congestion. They're often used prophylactically to prevent nasal congestion in patients with upper respiratory tract symptoms that are chronic. The adrenergic drugs like ephedrine and oxymetazoline are also used as topical nasal decongestants. Uh, the intranasal steroids are things like beclomethasone, which is Becanase, budesonide, which is Rhinocort, flunisolide, which is nasisolide, fluconazole, which is Flonase, and triamcinolone, which is Nasacort. These are kind of common things that are out there that are used. Intranasal anticholinergics are things like ipratropium, which is Atrovent. The mechanism of actions for nasal decongestants is that they act on the blood vessels surrounding the nasal sinuses. The adrenergics constrict the small blood vessels that supply the upper respiratory tract structures, and so as a result, these tissues shrink and the nasal secretions in the swollen mucous membranes are better able to drain. The nasal steroids have a direct anti-inflammatory effect. They work to turn off the immune system cells involved in the inflammatory response. The decreased inflammation results in decreased congestion. Like we've been talking about, the nasal decongestion indications are for the relief of nasal congestion that's associated with acute or chronic rhinitis, the common cold, sinusitis, hay fever, and other allergies. It may also be used to reduce swelling of the nasal passage and facilitate visualization of the nasal or pharyngeal membranes before surgery or for diagnostic procedures. The contraindication for nasal decongestions include our usual drug allergy, nasal narrow angle glaucoma, uncontrolled cardiovascular disease and hypertension, diabetes, and hyperthyroidism. And if you think about it, the inability to close the eyes that go along with hyperthyroidism. A history of cerebral vascular accident or transient ischemic attacks, in other words, stroke, or long-standing asthma, BPH, and diabetes. Adverse effects that are associated with nasal decongestions include nervousness, insomnia, palpitations, tremors. These are systemic effects caused by adrenergic stimulation of the heart, the blood vessels, and the CNS. So think back to those adrenergic drugs and what they do to the body. Also, with the steroids, it's associated with local mucosal dryness and irritation. There's a number of interactions with other drugs associated with nasal decongestants, and these include systemic sympathogenic drugs and sympathetic nasal decongestants are likely to cause drug toxicity when they're given together. The MAOI, or the monoamine oxidase inhibitors, which is a psych drug, and the sympathetic nasal decongestants raise blood pressure when they're given together. Methyl-dopa has the same type of effects. If you give it with urinary acidifier and alkalinizers, it also has a tendency to increase their effects. The nursing implications associated with the nasal decongestants include that the patient should avoid caffeine and caffeine-containing products. The caffeine acts on the same adrenergic sites, so we end up with a great increase to heart rate and blood pressure when they're taken together. Patients should report a fever, cough, or other symptoms lasting longer than a week, and monitor for the intended therapeutic effects as well as the unintended. Here's another question. Before administering an adrenergic decongestant, it is most important for the nurse to assess the patient for a history of cataracts, gastric ulcer, diabetes mellitus, or hypothyroidism. Well, the answer here is C. Adrenergic drugs are contraindicated in patients with narrow angle glaucoma, uncontrolled cardiovascular disease, hypertension, diabetes, and hyperthyroidism. They are also contraindicated when the patient is unable to close his or her eyes, like after a cerebral vascular accident, as well as in patients with a history of cerebral vascular accident or transient ischemic attacks, long-standing asthma, BPH, or diabetes. Now we'll deal with another one of those symptoms of the cold, and that's cough. Let's look at the physiology behind it. The respiratory secretions and foreign objects are naturally removed by the cough reflex. It induces coughing and expectoration, and it's initiated by irritation of the respiratory tract sensory receptors. They're there for a reason, to keep stuff out of your lungs. There's two basic types of cough: a productive cough, which comes from congestion and it removes excessive secretions, and a non-productive cough, which we call a dry cough. Most of the time, coughing is beneficial. It removes the excessive secretions and removes potentially harmful foreign substances. In some situations, though, coughing can be harmful, like after you've had a hernia repair surgery or some other situation where you don't want to increase the intrathoracic or the intra-abdominal pressure. Antitussives are drugs that are used to stop or reduce coughing. They consist of opioid and non-opioid medications. They are used only for non-productive coughs. They may be used in cases when coughing is harmful. The mechanism of action for antitussives with the opioid versions is that they suppress the cough reflex by direct action on the cough center in the medulla. It's an analgesia drying effect on the mucosa of the respiratory tract, and it increases the viscosity of the respiratory secretions. So you end up with a reduction of the runny nose and the postnasal drip that may be causing the cough. Examples of these medications include codeine and hydrocodone. The mechanism of action for the non-opioids is that, for instance, dextromethorphan works in the same way, but it's not an opioid. There's no analgesic properties to it and no CNS depression. Benzoate suppresses the cough reflex by numbing the stretch receptors in the respiratory tract and prevents the reflex stimulation of the medullary cough center. So in other words, what's happening is it numbs the receptor in the respiratory system, and so the message doesn't get sent up to the brain to cough, and so the person doesn't cough. So obviously the indication is used to stop the cough reflex when the cough is non-productive or harmful. The contraindications are, again, if you have a drug allergy to those medications. If you have an opioid dependency, you don't want to give somebody an opioid to stop them from coughing. If there's respiratory depression, so maybe if you've had a head injury, you don't want to be giving somebody a cough, an antitussive, because it will have an additive effect. And there's some other contraindications as well. Benzonatate can cause dizziness, headache, sedation, nausea, and other side effects when given. Dextromethorphan can cause dizziness, drowsiness, and nausea. And opioids can cause sedation, nausea, vomiting, lightheadedness, and constipation. There's a number of nursing implications when we're looking at antitussives. First of all, we want to perform a respiratory and cough assessment and assess for allergies potentially for these medications. We want to instruct patients to avoid driving or operating heavy equipment because of the possible sedation, drowsiness, or dizziness. We want to report any of the following symptoms to the caregiver: a cough that lasts more than 1 week, persistent headache, fever, or rash. This is signs of allergies. Antitussive drugs are for non-productive coughs. Although sometimes when people aren't sleeping very well because they're getting woke up all the time by their cough, the physician may order a antitussive for them to take at night so that they can get some good rest, because we know you need rest to be able to fight an infection that may be causing the cough. So, but in general, we look at antitussives for non-productive coughs. We want to monitor for the intended therapeutic effect as well as the unintended effects. A 94-year-old patient has a severe dry cough. He has coughed so hard that his muscles in his chest are hurting. He is unsteady on his feet and slightly confused. Which drug would be the best choice for this patient's cough? Benzonatate, also known as Tessalon pearls, which are little capsules that kind of look like yellow pearls. Dextromethorphan or Robitussin DM, an oral solution. Codeine cough syrup, or Guaifesin, Mucinex. Well, the answer on this one is B. Dextromethorphan does not cause respiratory or CNS depression, and it is not an opioid. Guaifesin is an expectorant that is used to thin excessive mucus, which this patient doesn't have. Expectorants are drugs that aid in the expectoration or removal of mucus, or you might say being able to spit it out. It reduces the viscosity of the secretions. In other words, it makes them thinner, and it disintegrates and thins the secretions. So an example of drugs that are expectorants are Guaifesin. The mechanism of action for expectorants is they act on reflex stimulation. The drug causes irritation of the GI tract. It loosens and thins the respiratory tract secretions that occur in response to this irritation. With direct stimulation, the secretory glands are stimulated directly to increase their production of respiratory tract fluids. That results in thinner mucus that's easier to cough up or to remove. The drug effect of expectorants is by loosening and thinning sputum and bronchial secretions. The tendency to cough is then indirectly diminished because you're able to get those secretions out easier when you do cough. The indications are for use of the relief of productive coughs associated with the common cold, bronchitis, laryngitis, pharyngitis, coughs that are caused by chronic paranasal sinusitis, pertussis, influenza, and measles. The nursing implications surrounding expectorants is that they should be used with caution in older adults and patients with asthma or respiratory insufficiency. Remember, patients with asthma don't usually have a lot of secretions associated with it. Patients taking expectorants should receive more fluids, if permitted, to help loosen and liquefy secretions. So when we say if permitted, if we're giving it to somebody who has a heart condition where we need to limit the amount of fluids that they're taking in order to avoid having congestive heart failure, then we're not going to be able to give them any extra fluids. But for the average person taking expectorants, you want to make sure that they're getting plenty of fluids in, because if you don't have fluids in your body to help loosen the secretions, it's not going to loosen up. We want their patients to report a fever, cough, or other symptoms that are lasting longer than a week, and monitor for intended the therapeutic effects as well as adverse effects. So now we'll go back and talk about this herbal product of echinacea. It reduces the symptoms of the common cold and it decreases the recovery time. And I think that's the really important aspect of echinacea. By improving the immune system and by acting on white blood cells so that you produce more white blood cells to fight an infection, it has a tendency to reduce the overall time that it takes to recover. Some of the adverse effects that are associated with echinacea include nausea, vomiting, stomach pain and diarrhea, fever and sore throat, muscle and joint pains, sometimes an unusual or unpleasant taste in the mouth, dry mouth, or a numb feeling of the tongue, headache, dizziness, confusion, and some people get insomnia associated with it. One more question about this chapter. A patient with a tracheostomy developed pneumonia. It is very difficult for the patient to cough up the thick, dry secretions he has developed. The nurse identifies which drug as being the most effective in helping this patient: benzonatate, dextromethorphan, codeine cough syrup, or guaifenesin. So obviously the answer here is the guaifenesin. It's an expectorant and it's used to aid in coughing up the secretions that's accumulated in the respiratory tract by breaking down and thinning them out. This chapter is going to talk about diseases of the lower respiratory tract. And so let's start out with that COPD. Chronic obstructive pulmonary disease can include asthma that's persistent and present most of the time despite treatment, emphysema, and chronic bronchitis. Bronchial asthma is recurrent and reversible shortness of breath that occurs when the airways of the lungs become narrowed as a result of bronchospasm, inflammation of the bronchial mucosa, edema of the bronchial mucosa, and production of viscous mucus. The alveolar ducts and alveoli remain open, but airflow to them is obstructed. As a result, we get wheezing and difficulty with breathing. There are 4 categories of asthma: intrinsic, in other words, occurring in patients with no history of allergies; extrinsic, occurring in patients exposed to known allergens; exercise-induced; and drug-induced. The National Institute of Health has recommended a stepwise therapy for the management of asthma. And you can read here how you start out with step 1. If step 1 is not sufficient, then you move to step 2 and on up until finally you're up at step 6. Status asthmaticus is a very severe form of asthma. It results in prolonged asthma attack that does not respond to the typical drug therapy. It may last several minutes to several hours. It is considered a medical emergency. Chronic bronchitis is the continuous inflammation and low-grade infection of the bronchi. There's excessive secretion of mucus and certain pathologic changes in the bronchial structure. It often occurs as a result of prolonged exposure to bronchial irritants like cigarette smoking. Emphysema is when the airspace is enlarged as a result of the destruction of the alveolar walls. It's caused by the effects of proteolytic enzymes released from leukocytes in response to alveolar inflammation. So let's take this down to simple words. It's caused by the effect of, of protein enzymes that break down the proteins in the tissues of the alveolar walls, and these proteolytic enzymes are released from white blood cells in response to the inflammation of those alveolar walls. The surface area where the gas exchange takes place is reduced because of the scarring and change in those tissues. And so effective respiration becomes impaired. Besides some of the other medications that we've already talked about, there's a number of other medications that we use specifically for these conditions. The first one is bronchodilators. These drugs relax the bronchial smooth muscle, which causes dilation of the bronchi and the bronchioles that are narrowed as a result of the disease processes. There's three classes of bronchodilators: beta adrenergic agonists, anticholinergics, and xanthine derivatives. Looking at the beta adrenergic agonists, there's two forms of those. The short-acting beta agonists, or SABA inhalers, which include albuterol, which, by the way, has several different names, including Ventolin, ProAir, and another one that I can't think right off the top of my head. Levobuterol, pyrbuterol, terbutaline, which is breathine, and metoprolol or alupent. If you notice, except for the terbutaline, they all end with the erol as the end. The long-acting beta agonists, or LABA inhalers, are arformoterol, formoterol, and salmeterol. There are several newer bronchodilators that are LABAs, and they include indacterol, vilanterol, which is used in conjunction with fluticasone, vilaterone, that's used in conjunction with an anticholinergic, umecilidinium, and the term ellipta in this medication refers to the new delivery system that they're utilizing. The beta adrenergic agonists are used during the acute phase of asthmatic attacks. They quickly reduce the airway constriction and restore normal airflow. They are agonists or stimulators of the adrenergic receptors in the sympathetic nervous system. So, in other words, they're sympathomimetics. There are three types of beta adrenergic agonists. The non-selective adrenergics, they stimulate the alpha, the beta, and the beta 2 receptors. An example of this would be epinephrine, like with the EpiPen. Non-selective beta adrenergics stimulate both the beta and beta 2 receptors. An example of these would be metoprolol. Selective beta 2 drugs stimulate only the beta 2 receptors, and an example of that would be albuterol. The mechanism of action for the beta adrenergic agonists is that it begins at the specific receptor stimulated. So, in other words, it starts right where you stimulate it to start. It ends with dilations of the airways. The activation of the beta 2 receptors activates the cyclic adenosine monophosphate, or the cAMP, which relaxes the smooth muscles in the airway, and it results in bronchial dilation and increased airflow. Beta adrenergic agonists are indicated in the relief of bronchospasm related to asthma, bronchitis, and other pulmonary diseases. It's used in treatment and prevention of acute attacks, and it's also used in hypotension and in shock. Contraindications for beta adrenergic agonists include obviously a known drug allergy, uncontrolled hypertension. Think about the fact that if you aren't doing something for your hypertension and you take a adrenergic drug, it's going to act on the heart and it's going to cause you to have increased blood pressure. You already have increased blood pressure, so it can increase the risk of stroke or other things, or heart attack, depending on what your history is like. If there's cardiac dysrhythmias, or there's a high risk of stroke because of vasoconstrictive drug actions. Adverse effects that are associated with the beta adrenergic agonists, again, think about the adrenergic system and what happens when we stimulate it. With epinephrine, we can get both alpha and beta adverse effects. So we may get insomnia, restlessness, anorexia, vascular headache, hyperglycemia, tremor, and cardiac stimulation. So what's going to happen to the heart? The heart's going to be beating fast. Beta 1 and beta 2 adverse effects, like with metoprolol, is going to be things like cardiac stimulation, so increased heart rate, tremor, anginal pain, vascular headache, and hypotension. With albuterol or beta 2 stimulation, we're going to have hypotension or hypertension, vascular headache, and tremor. There is interactions between the beta adrenergic agonists and other drugs. There's diminished bronchodilation when non-selective beta blockers are used with beta agonist bronchodilators. There is action with the monoamine oxidase inhibitors, or the MAOI, psychiatric drugs, those drugs seem to have effects with a lot of other drugs. There's reactions with the sympathomimetics, so it's going to increase the reaction because these are drugs that are similar to those. And you want to monitor patients with diabetes for an increase in blood glucose levels that can occur. Remember, these drugs are your fight or flight drugs. So, what do you need in order to flight? Well, you need more glucose in your system so that you're able to move. So, somebody who's diabetic doesn't need more glucose added into their system. So let's look at these drugs individually. Albuterol, which is also known as Proventil, ProAir, and Ventolin, is a short-acting beta-2 specific bronchodilating beta agonist. It is the most commonly used drug in this class. It must not be used too frequently. If you're using it several times a day, you need to be started on another medication to help control your asthma or your COPD better. It comes in both an oral and inhaled form. The inhalational dosage forms include a metered dose inhaler or an MDI, as well as solutions for inhalation. Salmeterol, or Ceravent, is a long-acting beta-2 agonist bronchodilator. It should never be used for acute treatment. It's used for maintenance treatment for asthma and COPD, and is used in conjunction with an inhaled corticosteroid. Salmeterol should never be given more than twice daily, nor should the maximum daily dose of 1 puff twice daily be exceeded. When we look at the anticholinergics mechanism of action, the acetylcholine causes bronchial constriction and narrowing of the airways. Anticholinergics bind to the acetylcholine receptors, preventing acetylcholine from binding. The result is bronchoconstriction is prevented and the airways dilate. There are several anticholinergics that are kind of the prototypes for these. Ipratropium, or Atrovent, or Tiotropium, which is Pariva, or Aslidinium, which is Tudorza, are three that we think of right off the top of our head. They indirectly cause airway relaxation and dilation, and they help reduce secretions in COPD patients. So when you see Atrovent, Spiriva, or Dorza, and you need to learn the generic names on these, you should be thinking about treatments for COPD. The indication is prevention of bronchospasm associated with chronic bronchitis or emphysema, not for the management of acute symptoms. Adverse effects associated with anticholinergic drugs include dry mouth or throat, or both, nasal congestion, heart palpitations, gastrointestinal distress, headache, coughing, and anxiety. So think about these anticholinergic drugs. Remember, the cholinergic system is the rest and relax system. How rest and digest. So what ends up happening with these medications, though, in the lungs is they cause constriction. And so the anticholinergic are going to do the opposite of the rest and digest. So what's going to happen is we're going to get the dry mouth, we'll get the heart palpitations, and the GI distress. If you think about it, the nasal congestion that's caused by these anticholinergics are related to the fact that the vessels have been um, constricted because they're part of the respiratory system, but now they're all relaxed out, so now fluid can move through the vessel walls easier. Ipratropium, or Atrovent, is the oldest and most commonly used anticholinergic bronchodilator. It's available both as a liquid aerosol for inhalation and as a multi-dose inhaler. It's usually dosed twice a day. Xanthine derivatives are plant alkaloids, caffeine, theobromide, and theophylline. Only theophylline is used as a bronchodilator. There are synthetic xanthines that are aminophylline and diphylline that are related to these actual plant alkaloids. The mechanism of action for these xanthine derivatives is that they increase levels of energy producing cAMP. This is done by competitively inhibiting the phosphodiesterase enzyme that breaks down cAMP. The result is decreased cAMP levels, smooth muscle relaxation, bronchodilation, and increased airflow. So how does the drug act? It causes bronchodilation by relaxing smooth muscles in the airway. The result is relief of a bronchospasm and greater airflow into and out of the lungs. It can also cause central nervous system stimulation and also cause cardiovascular stimulation, which means an increased force of contraction, increased heart rate, resulting in increased cardiac output and increased blood flow to the kidneys, the diuretic effect. Indications for xanthine derivatives include dilation of the airways in asthma, chronic bronchitis, and emphysema. Mild to moderate cases of acute asthma, but not for the management of acute asthmatic attacks. It is also an adjunct drug in the management of COPD and not used as frequently because of the potential for drug interactions and variables related to drug levels in the blood. Adverse effects associated with xanthine derivatives include nausea, vomiting, anorexia, gastroesophageal reflux, especially during sleep, sinus tachycardia, extrasystole palpitations, ventricular dysrhythmias, transient increased urination that can result in dehydration, and hyperglycemia. So we don't very often think about caffeine as being a drug, but in actuality it is because it's a xanthine derivative. It's used without prescription as a CNS stimulant or an analeptic to promote alertness, like when you're driving for a long time or you want to stay up late to study. It's a cardiac stimulant in infants with bradycardia and for enhancement of respiratory drive in infants. I want to clarify how this is phrased in your book. Premature infants have something known as apnea of prematurity. Apnea of prematurity is basically caused by a immaturity of the medulla telling that child to take their next breath. So what happens with it is with caffeine, it will stimulate the respiratory center to tell them to take their next breath. It prevents them from getting bradycardic when they don't take that next breath. So what happens with them with apnea of prematurity is they go longer than 20 seconds without taking a breath. That length of time on an infant is way too long. On an adult, 20 seconds is no big deal. But babies breathe around 40 to 60 breaths per minute, so they need to have more frequent breaths. When they go that longer distance, what happens is their heart rate starts to drop in response to the decreased oxygenation and increase in CO2. So what happens with caffeine is it acts directly on that respiratory center and it keeps them breathing that, and it also keeps them from having the bradycardia that happens when they go a little bit too long without breathing. Theophylline is the most commonly used xanthine derivative. It comes in a oral, rectal, and injectable. You won't find injectable theophylline. It's aminophylline, which is the synthetic version, and topical dosage forms. Aminophylline is used IV for treatment of patients with status asthmaticus who have not responded to the fast-acting beta agonists like epinephrine. It used to also be given in the premature babies to prevent apnea of prematurity. However, what they discovered was that it had a lot of metabolites that happened as it was being broken down, that had a lot of nasty side effects. And what they discovered was that as theophylline was being broken down, it turned into caffeine. And it was the caffeine part of the breakdown of theophylline that was actually benefiting the babies. And so rather than giving them this drug that required a lot of breaking down to get the action that we wanted, we started giving them directly caffeine, and then that was shown to work much, much better for the babies because they didn't have all these other side effects. The therapeutic range for theophylline, remember, this is one of those drugs that we have to worry about drug levels, that we can get too much of it and we can measure the drug level to find out what's going on. It has a narrow range between 10 to 20 micrograms per milliliter. However, most clinicians are now advising that the levels be between 5 and 15. So chances are, if you were to see a question about aminophylline or theophylline on a NCLEX exam, they would be asking you something about a patient whose level was in that 10 to 15 range, and they would be asking you whether it was a normal range or low or high or whatever. Either that, or they'd want to know if the level was too high, and they would be giving you symptoms of somebody who had a high level of theophylline. So there's a few non-bronchodilating respiratory drugs that we use as well to help with asthma and COPD. One group is known as the leukotriene receptor antagonists. Montelukast is one of those, and probably one that you would recognize the most, and it's known as Singulair. Zafirlukast and Zaluton are other forms of leukotriene receptor antagonists. Corticosteroids like beclomethasone, budesonide, dexamethasone, fluticasone, and these other steroids are also rather familiar for people who have asthma and COPD. Mast cell stabilizers are becoming more rarely used, and they include things like cromolyn and netochromil, which are sometimes used for exercise-induced asthma. So let's talk a little bit about these leukotriene receptor antagonists, or LTRAs. They are non-bronchodilating. They are a newer class of asthma medications, and the currently available drugs include montelukast, zafirlukast, and Zulitroton. We'll talk about how these LTRAs act on the body. Leukotrienes are substances that are released when a trigger like cat hair or dust mites starts a series of chemical reactions in the body that we call the inflammatory reaction. The leukotrienes cause inflammation, bronchoconstriction, and mucus production. So as a result, we start coughing, wheezing, and have shortness of breath. So the LTRAs prevent the leukotrienes from attaching to the receptors on the cells in the lungs and in the circulation. So the inflammation in the lungs is blocked and the asthma symptoms are relieved. The drug effects are there by blocking the leukotrienes to prevent smooth muscle contractions of the bronchial airways. They decrease mucus secretions, they prevent vascular permeability, and they decrease neutrophil and leukocyte infiltrations into the lungs, and that prevents inflammation. Um, Montelukast itself is also, if you look at these effects by blocking the leukotrienes, they're also known as medications that help with allergic reactions as well. The indication of LTRAs include prophylaxis and long-term treatment and prevention of asthma in adults and children 12 years of age and older. They are not meant for management of acute asthmatic attacks. Montelukast is also approved for the treatment of allergic rhinitis, and you should see improvement with their use typically in about a week. So what happens with these drugs is if you're having to use your albuterol inhaler frequently, they will start you on these LTRAs, and you should see a reduction in the use of the inhaler because you're not getting the inflammatory responses. Indications to LTRAs, besides known drug allergy, is previous adverse drug reactions, allergies to povidone, which is betadine, lactose, titanium dioxide, or cellulose derivatives, because these are inactive ingredients in these drugs. The LTRA's adverse effects, specifically uh, Xeluton is headache, nausea, dizziness, and insomnia. And Zirflucast and Montelukast is headache, nausea, and diarrhea. Corticosteroids, specifically glucocorticoids, are, are given for their anti-inflammatory properties. They're used for chronic asthma. They do not relieve the symptoms of acute asthma attacks. They may be administered by IV. However, they're also in oral or inhaled forms. The inhaled forms reduce the systemic effects. So, in other words, we know what the systemic effects of steroids are, but the inhaled forms are such a small dose that you don't tend to get those systemic effects. It may take several weeks before full effects are seen when corticosteroids are used. Corticosteroids work by stabilizing the membranes of leukocytes that release bronchoconstricting substances when the inflammatory system is stimulated. It increases the responsiveness of the bronchial smooth muscles to beta adrenergic stimulation. So we want the cells in the lungs to be sensitive to those beta adrenergic drugs that we're giving so that we don't have the bronchoconstricting action. There's a dual effect of both reducing inflammation and enhancing the activity of the beta agonists with corticosteroids. And this is a huge advantage when we give these drugs together. They have been shown in studies to restore or increase the responsiveness of bronchial smooth muscle to beta adrenergic receptor stimulation, which results in a more pronounced stimulation of the beta 2 receptors by beta agonist drugs such as albuterol. So if we've been using albuterol by itself and then we add a corticosteroid, it may have gotten so that albuterol by itself just isn't working anymore. But we add the steroid to it and it will decrease the inflammation, but it will also make that beta 2 medication, that albuterol, work better. The indication for inhaled corticosteroids include the primary treatment of bronchospastic disorders to control the inflammatory responses that are believed to be the cause of these disorders, for persistent asthma, and often used concurrently with beta adrenergic agonists. Also, for the systemic, corticosteroids are generally used only to treat acute exacerbations or severe asthma. IV corticosteroids are specifically for the acute exacerbation of asthma or other COPD diseases. Often what we do when we're using corticosteroids is we will give a dose of a beta 2 agonist like albuterol that relaxes the bronchoconstriction. Then we give the corticosteroid so that now we've got a nice open airway so that when we give the steroid can get farther down in the lung and be able to act on the inflammatory process that's down further in the lung. Contraindications for corticosteroids include drug allergies. It's not intended as sole therapy for acute asthma attacks. Usually we have a combination of the beta 2 agonists and the steroids. Remember, the steroids take a while to work. Also, if there's a hypersensitivity to glucocorticoids, in patients whose sputum tests positive for Candida, we don't want to give them steroids because steroids are going to decrease their ability to fight off their infection. Also, with patients that have systemic fungal infections, if we give them a steroid in their lungs, it's going to make their lung more sensitive, and they could get a fungal infection in their lungs as well. Adverse effects that are associated with corticosteroids include pharyngeal irritation, coughing, dry mouth, and oral fungal infections, which we can do things to prevent that, and we'll talk about that in just a little bit. Also, we don't tend to get the systemic effects because the low doses that are used for inhalation therapy do not have the ability to have the strong effects that the systemic steroids have. So the results tend to stay in the lungs and not go to other parts of the body. When we look at these different drug interactions, we tend to have more interactions with the systemic corticosteroids than the inhaled corticosteroids. There may be an increase in serum glucose levels, possibly requiring adjustments in the dosages of the anti-diabetic drugs. With cyclosporins and tacrolimus, if the patient is on corticosteroids, it can require these drugs to be given at higher dosages than if they were being given on their own. These drugs are given, the cyclosporin and tacrolimus is given for their organ rejection drugs, so that they're keeping somebody from rejecting a donated organ. With itraconazole, it also needs to have higher doses given if steroids are being given at that time. Conversely, if somebody's on phenytoin, phenobarbital, or rifampin, it will actually make it so that the steroid doesn't work as well. All of these are related to how these drugs are metabolized in the liver, and so that's why they have the interactions that they do. There's also a drug group known as phosphodiesterase 4 inhibitors, and the drug that we think about with that is roflumilast. It's indicated to prevent coughing and excess mucus from worsening and to decrease the frequency of life-threatening COPD exacerbations. The adverse effects that are associated with it include nausea, diarrhea, headache, insomnia, dizziness, weight loss, and psychiatric symptoms. We also have some monoclonal antibiotics that are used as anti-asthmatics. Specifically, we have omalizumab, or Xolair. If you think again, these monoclonal antibodies end with MAB, M-A-B. It selectively binds to the immunoglobulin E, which in turn limits the release of mediators for allergic responses. Omalizumab is given by injection, and there's a potential for producing anaphylaxis because of that. Any of these monoclonal antibodies have a risk for anaphylaxis, and many of them are given either IV or IM. We want to monitor closely for hypersensitivity reactions when we use these medications, and often they will be given in a situation so that somebody is there to monitor the child or the adult after they've received these monoclonal antibodies. And now it's time to look at all the nursing implications about these drugs. We want to encourage our patients to take measures to promote and stay in a generally good state of health so as to prevent, relieve, or decrease symptoms of COPD. So they should avoid exposure to conditions that precipitate bronchospasms like allergens, smoking, stress, and air pollutants. We want them to have adequate fluid intake and be in compliance with their medical treatment. They should avoid excessive fatigue, heat, extremes in temperature, and caffeine. Remember, caffeine constricts the airways. We want to encourage patients to get prompt treatment for flu or other illnesses and to get vaccinated against pneumonia or flu. We want to make sure to perform a thorough assessment before beginning therapy, including assessing skin color, baseline vital signs, respirations, which in adults ought to be between 12 and 24 breaths per minute, respiratory assessment, including pulse oximetry, sputum production, allergies, history of other respiratory problems, and what other medications they're taking. We want to teach the patients to take their bronchodilators exactly as prescribed. Encourage them to always check with their physician before taking any other medications, including over-the-counter medications. Ensure that the patients know how to use their inhalers and their MDIs, and have the patients demonstrate uses of those devices so that they aren't at home and suddenly realize they don't know how to do it because they've never actually done it. So we want to also monitor for adverse and therapeutic events. Which medication will the nurse teach a patient with asthma to use when experiencing an acute asthma attack? Albuterol, salmeterol, theophylline, or montelukast? Well, we know that the answer to this is albuterol because albuterol or Ventolin or ProAir is a short-acting beta agonist. Patients must be taught to use their SABAs as rescue treatment. Salmeterol is a long-acting bronchodilator because the LABAs have longer onset of action. They never should be used for acute treatment. Because of their relatively slow onset of action, xanthines like theophylline, which is also known as Theodore, are more often used for prevention of asthmatic symptoms than the relief of acute asthma attacks. Montelukast is an LTRA and is used primarily for oral prophylaxis and long-term treatment of asthma. We want to monitor for therapeutic effects. We should see decreased dyspnea, decreased wheezing, restlessness, and anxiety, improved respiratory patterns with return to normal rate and quality. We should see improved activity tolerance and decreased symptoms and increased ease in breathing. The beta adrenergic agonists, like albuterol, if it's used too frequently, loses its beta 2 specific actions at larger doses. So as a result, the beta 1 receptors are stimulated, causing nausea, increased anxiety, palpitations, tremors, and increased heart rate. So we want to ensure that the patients take their medications exactly as prescribed, with no emissions and no double doses. We want to inform the patients to report insomnia, jitteriness, restlessness, palpitations, chest pain, or any changes in symptoms. A patient with chronic bronchitis calls the office for a refill of his albuterol inhaler. He just had a prescription filled 2 weeks ago, but he says it's empty. When asked, he tells the nurse, "I use it whenever I need it, and now when I use it, I feel so sick. I've been needing it to use it more often." What is the most appropriate action by the nurse? A. The nurse should confirm the pharmacy location for the needed refill. B. The nurse should ask the patient to come to the office for an evaluation of his respiratory status. C. The nurse should tell the patient not to use his drug too often. D. The nurse should consult the prescriber for a different inhaler prescription. Well, the answer to this one is B. Although it's true that the patient should be reminded about the correct use of this inhaler, it's evident that he has used it too often and that his respiratory status should be evaluated to see if an adjustment in the prescription should be made. In other words, he may need one of these long-acting dilators to be added to his regimen so that he doesn't feel like he needs to use that albuterol so often. The nursing implications for xanthine derivatives include the contraindications, especially a history of PUD, which is peptic ulcer disease, or GI disorders. Cautious use needs to be noted for people with cardiac disease. The time to release preparations should not be crushed or chewed because they will cause gastric irritation. Make sure to teach the patient to report to the prescriber if they are having nausea, vomiting, restlessness, insomnia, irritability, and tremors. Remember what I told you. Theophylline and aminophylline and these other drugs are broken down to caffeine. So think what happens when you drink too much caffeine. You get irritability, you get insomnia, you tend to get restless, and if you really ate enough of it, you'd get nausea and vomiting and other side effects. Be aware of drug interactions with cimetidine, oral contraceptives, allopurinol, and certain antibiotics, influenza vaccine, and others with these xanthine derivatives. Cigarette smoking enhances xanthine metabolism. So that means it's going to wear off much faster. And not to mention that that may be one of their causes of having their COPD or asthma in the first place. Interacting foods include charcoal broiled, high protein, and low carbohydrate foods. These foods may reduce the serum levels of xanthines through various metabolic mechanisms. The nursing implications regarding the LTRAs include ensuring that the drug is being used for chronic management of asthma and not an attempt to use it for acute asthma. You want to teach the patient the purpose of the therapy and that improvement should be seen in about a week. You want to advise the patients to check with their prescriber before taking over-the-counter or prescribed medications to determine the drug interactions. Assess liver function before beginning therapy and throughout therapy. You want to teach patients to take their medications every night on a continuous schedule, even if their symptoms improve. When working with patients that are on inhaled corticosteroids, the nursing implications include teaching the patients to gargle and rinse their mouth with lukewarm water afterwards to prevent the development of oral fungal infections. If a beta agonist bronchodilator and a corticosteroid inhaler are both ordered, the bronchodilator should be used several minutes before the corticosteroid to provide bronchodilation before administration of the steroid. We want to ensure that we teach the patients to monitor their disease with a peak flow meter. Also encourage the use of a spacer device to ensure successful inhalations, especially with children. Children aren't very good at squeezing their inhaler and taking a breath at the same time, so the spacer device allows a longer period of time for them to inhale their medication. Also, teach the patient how to keep the inhalers and nebulizer equipment clean to avoid infections with fungal diseases. Patient education for anyone that's prescribed an inhaler is to ensure that they are able to self-administer their medication. You want to provide a demonstration and a return demonstration to ensure that the patient knows the correct time intervals for their inhalers and how to give them. You want to provide a spacer if the patient has difficulty coordinating breathing with the inhaler activation, and ensure that the patient knows how to keep track of the number of doses in the inhaler device so they don't suddenly find themselves without any medication. A patient is prescribed 2 different types of inhaled medication for treatment of COPD. After administering the first medication, how long should the nurse wait to administer the second medication? 1 minute, 5 minutes, 10 minutes, or 15 minutes? The answer to this is B. If a second puff of the same drug is ordered, instruct the patient to wait 1 to 2 minutes between puffs. If a second type of inhaled drug is ordered, instruct the patient to wait 2 to 5 minutes between the medications or to take as prescribed. Bronchodilators are usually administered first with their other medications delivered after that.